Alirocumab and cardiovascular outcomes after acute coronary syndrome. Definition. What is an acute coronary syndrome? An acute coronary syndrome occurs when atherosclerotic coronary plaque becomes unstable, leading to a series of events, eventually resulting in a partial or total thrombotic occlusion of a coronary artery. Acute coronary syndromes are categorized into unstable angina, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction.
Acute coronary syndrome, or ACS, is a major cause of morbidity and mortality throughout the world. ACS is a constellation of clinical symptoms that ranges from unstable angina to non-ST segment elevation myocardial infarction to ST segment elevation myocardial infarction. Most acute coronary events occur as a result of thrombus formation, a process in which platelet activation plays an important role. Activated platelets release a variety of substances, including the potent platelet agonist adenosine diphosphate, or ADP. The binding of ADP to P2Y12 receptors on the platelet surface is a critical step in amplifying the structural and metabolic changes associated with platelet activation. Because of its important role in platelet activation, the binding of ADP to the P2Y12 receptor is a target for pharmacologic intervention with antiplatelet drugs.
Patients who have had an acute coronary syndrome are high risk for recurrent ischemic cardiovascular events. We thought to determine whether alirocumab, a human monoclonal antibody to protein convertase cerylation casein type 9 (PCSK9) will improve cardiovascular outcomes after acute coronary syndrome in patients receiving high-intensity statin therapy. Despite the availability of evidence-based treatments, patients who have had an acute coronary syndrome remain at high risk for recurrent ischemic cardiovascular events.
Patients with acute coronary syndrome are at risk for recurrent ischemic cardiac events. Some of this risk is attributed to elevated levels of low-density lipoprotein, or LDL, cholesterol, and other atherogenic lipoproteins. Proprotein convertase subtilisin kexin type 9, or PCSK9, promotes the degradation of LDL receptors, which results in decreased clearance of LDL from the circulation. A monoclonal antibody to PCSK9, Alirocumab, has been shown to reduce LDL cholesterol when administered alone or with statins. This randomized controlled trial involved 18,924 patients who had been hospitalized for myocardial infarction or unstable angina in the previous 1 to 12 months, and who had one of the following despite high-intensity or maximum tolerated statin treatment: an LDL cholesterol level of at least 70 milligrams per deciliter, a non-high-density lipoprotein cholesterol level of at least 100 milligrams per deciliter, or an apolipoprotein B level of at least 80 milligrams per deciliter. Patients were randomized to receive either 75 milligrams of alirocumab or placebo subcutaneously once every 2 weeks, and were followed for a median of 2.8 years. Alirocumab was titrated in a masked fashion to achieve a target LDL cholesterol level between 25 and 50 milligrams per deciliter. The primary endpoint, a composite of death due to coronary heart disease, non-fatal myocardial infarction, ischemic stroke, or unstable angina requiring hospitalization, was significantly less frequent in the alirocumab group than in the placebo group. Adverse events were similar between the two groups except for local injection site reactions, which were more frequent with alirocumab. The authors conclude that alirocumab reduced major adverse cardiovascular events in patients with a recent myocardial infarction or unstable angina as compared with placebo. Full trial results are available.
Advantage is recommended for treating primary non-familial hyperscolemia or mixed dyslipidemia in adults with a high risk of cardiovascular disease and persistent LDL cholesterol levels of at least 4.0 mol-liters despite having the maximum tolerated lipid-lowering therapy. The absolute benefit of alirocumab with respect to the composite primary endpoint was more pronounced among patients who had a baseline LDL cholesterol level of 100 mg or more per deciliter than among patients with a lower baseline LDL cholesterol level. Disadvantage is not recommended for treating non-familial hyperescolemia or mixed dyslipidemia in adults without a history of cardiovascular disease. New and powerful way to reduce bad cholesterol that has profound implications is dealing with the signs of vascular disease, which can lead heart attacks and strokes.
PCSK9 inhibitors explained in 3 minutes. Let's begin. PCSK9 inhibitors are a new type of monoclonal antibody medication used to treat high cholesterol. You may have been prescribed a PCSK9 inhibitor if you are unable to achieve a sufficiently low cholesterol level on your current medications, or if you are unable to tolerate other cholesterol-lowering medications. There are currently 2 types of PCSK9 inhibitors on the market: Alirocumab, or its brand name Praluent, and Evolocumab, or its brand name Repatha. Both medications have the option to be injected subcutaneously once every 2 weeks or once a month. They are usually quite expensive, but both companies may offer some sort of compassion program to help cover the costs if you meet their criteria. So, how do PCSK9 inhibitors work? Well, LDL cholesterol, or low-density cholesterol, is the main type of cholesterol that is reduced by this drug. So, LDL cholesterol is normally removed from the blood by the liver. LDL receptors on the liver bind to LDL cholesterol, and this allows the LDL cholesterol to be removed in the liver, causing a reduction of LDL cholesterol in the blood. Now, PCSK9 is an enzyme in the body that helps regulate cholesterol levels. It normally binds to LDL receptors and tags them for degradation. With fewer LDL receptors, the liver cells can no longer remove as much LDL cholesterol from the blood. PCSK9 inhibitors are monoclonal antibodies that target the PCSK9 enzyme. By binding to this enzyme, PCSK9 is no longer able to bind to LDL receptors and cause their degradation. This allows the LDL receptors on the liver cells to remain active and to continue removing LDL cholesterol from the blood, and this causes a reduction in blood LDL cholesterol levels.
Among patients who had a previous acute coronary syndrome and who were receiving high-intensity statin therapy, the risk of recurrent ischemia cardiovascular events was lower among those who received alirocumab than among those who have received placebo.
So we did the Odyssey outcomes trial to test the hypothesis that patients with recent ACS not at goal on maximal statin therapy would derive clinical benefit in terms of outcomes from adding alirocumab to their secondary prevention therapy. And we did this because despite all the progress we've made in the care of ACS patients, they remain at substantial residual risk. In fact, they are the group of all patients with acute coronary disease, with coronary artery disease, who have the highest risk of subsequent adverse events. So we tested this in a large outcomes trial, enrolling patients not at goal on truly maximal statin therapy following an ACS 1 to 12 months prior to that. It was a double-blind randomized trial Patients received either Alirocumab or placebo every 2 weeks subcutaneously in blinded fashion. Median follow-up 2.8 years, high quality data. The results are very simple. Number one, we met our primary endpoint, which was a reduction in MACE by 15%, which is exactly what we set out to do. The next bonus finding that we did not expect was a 15% lower all-cause mortality in those patients. Now we have to be careful with the interpretation of that finding because of technicalities in the statistical analysis in which we pre-specified other events in the order of analysis. But still, all-cause mortality was lower, and that's an important finding.